Sorry about that. Um, Hi, everyone. I'm Marianne Girardi. I'm a physical therapist who's been practicing for over 30 years. I've been primarily practicing with adults and pediatrics with neurodisabilities and a multitude of settings. I joined Ultimate Medical back in November as their clinical education specialist, and I hope you enjoy this seminar and the other ones in the series that we're going to bring you the rest of the year. Um, in practicing over 30 years, my first job happened to be at a state school facility here in Massachusetts. They were residential facilities for adults and pediatrics with cognitive and physical impairments. They were first opened in 1922, and I was working there in the 80s. When they first opened, the residents who had physical disabilities pretty much spent their days either lying in bed or on floor mats. They had no interventions. And going through the histories when I was there, the medical histories, for a whole year of these people's lives, there was one sentence in their charts, which is kind of sad. They had no intervention. They were clothed and bathed and fed, but there was no physical therapy. There was no activities. And what ended up happening was they all developed severe deformities. A lot of the adults I'd seen when I got there in the 80s had such severe scoliosis and contractures that there was no way to correct them. There was one child who had a scoliosis of over 120 degrees. Her pelvis and her rib cage had actually passed. She was young enough that they could do a surgical intervention, and she went through 2 5-hour surgeries. She grew 6 inches, which was great, but we didn't have anything that fit her because everything was custom made back then. I had another student or resident that I worked with, and I was doing chest PT, and I was listening to his left lower lobe. And I heard sounds I'd never heard before. And I got very concerned that he was very ill. So I went and ran for the nurse practitioner, who came in and took a listen and said, that's his stomach. Because of the severe deformity of his spine and the rotation, his internal organs had all replaced, and his stomach was now in the position of where I would have expected everyone else to have their left lower lobe. Unfortunately, at that time, I thought that's what happened with CP. If you had CP, you got deformities, there was nothing you can do. 30 some odd years later, I now know that there is some things that we can do. And today we're going to talk about deformities, how they occur, common deformities in CP, and some interventions that you can implement to make some changes. So our learning objectives for today are to identify 3 contributing factors of postural deformities in children with CP, describe 3 components of a 24-hour positioning system, and identify 3 benefits of standing. We're going to be talking about gross motor functional classification scale. Pretty much we're talking about levels 4 and 5 children. Children in level 4 use methods of mobility that require physical assistance or powered mobility in most settings. They may walk for short distances at home with physical assistance or use powered mobility or a body support walker, i.e. gait trainer. And at school and outdoors, they're usually using a manual wheelchair and a powered mobility. Level 5 children are the most involved. They don't have a lot of movement. They don't have control of their anti-gravity muscles, and they're transported in a wheelchair in all settings. So can we prevent? This is my friend Lizzie. I met Lizzie 32 years ago when she was about 7 or 8 years old. She was one of my students in a school I worked at. And at that time, Lizzie presented with high tone, but she had normal range of motion. She had the ability to crawl. She could sit either in Indian sitting, or she could actually hold herself up in long sitting. She did have AFOs for standing. She used a stander 30 minutes a day, 3 times a week. Didn't know a whole lot then. She also had a classroom chair. She had a power chair that she used daily. But her parents didn't believe in positioning or equipment. When Lizzie got home, she was taken out of her wheelchair, which was left in the garage. Actually, she wasn't in high school before their house became accessible. And she crawled around the house. I met Lizzie again about 5 years ago. She was late 30s. And this is the deformity she formed. As you can see, she's got a subluxed hip, hip and knee flexion contractures, ankle contractures, a rotational scoliosis, a pelvic obliquity, and her left arm has had a couple of surgeries. She's pretty dependent for everything. She is able now. She does use a computer and self-feed, but she's not walking. She does have a standard that she uses on occasion. Her pelvic obliquity has impacted her seating. She has a custom seating system in both a power and a manual chair. But for the longest time, she had to have changes of position, get out of the chair every couple of hours because of pain, because of the severe pelvic obliquity. When I met Liz again a few years ago, it was like, what did I do wrong? What could I have done? And I think we just didn't understand enough about deformities earlier that we can do stuff. So let's talk about it. So first I'm going to ask you, what's Sweden known for? Is it ABBA? Is it preventing severe deformities in children with cerebral palsy or CP-like symptoms? CP-like symptoms are children who don't have the official diagnosis of CP, but they have the motoric and neurological symptoms. IKEA. Meatballs. All of the above. The answer is all of the above. Some more important than others. CPUP is the Cerebral Palsy follow-up program that was developed in Sweden back in the early 1994 in southern Sweden. It was only in a few of the counties in the southern Sweden. It became as a cooperative project between the pediatric orthopedics and the child rehab centers. They joined forces to try to figure out a way that they could help prevent and minimize the deformities that they were seeing. In 2020, 95% of the children with CP or CP-like symptoms are in the program. The program is totally voluntary. The families are offered the ability to enter the program, but it's not mandatory. What are the goals of CPUP? It's to prevent the occurrence of hip dislocation and severe deformities by means of a continuous and standardized surveillance, if necessary, combined with the treatment at an early age, and thereby optimize the functional ability and quality of life with those with CP. To gain knowledge about CP and to improve the cooperation between various professionals with respect to the people with CP. Children included in the CPUP are examined every 6 months, once a year, every other year, depending on their age and GMFS level. The systematic follow-up includes reports of surgery, CP subtype, radiographs of the hips, and standardized clinical examinations of passive range of motion and gross motor function. There is a standardized OT and PT eval that are filled out in their local areas and sent to the CPUP Center to be added to the database. It's an amazing database. They have over 20 years of data, and they use the children who were born in 1990 and 1991 before the program started as the control group. What CPUP has shown us is that we can prevent and minimize deformities. At the end of the 10 years, they did an evaluation and they found that they decreased surgical correction of deformities from 40 to 15% and decreased hip dislocations from 10% to 0.4%. After 20 years, they reevaluated all their data and found that they were able to maintain this level of decrease in deformities and in hip dislocation. Hip dislocation is probably one of the most common deformities, orthopedic deformities in children with CP. And what CPUP has shown us is that with intervention, we can make a difference and we can prevent this. It's painful. It affects their whole life. So let's try to do something about it. So what is a deformity? A deformity is an abnormality of the position of the body compared to a normal position. It can lead to secondary complications, including pain, respiratory issues, decreased motor skills. Besides the pain, the decreased motor skills, the respiratory issues are really important. It's one of the leading causes of mortality in people with CP, and over 50% of the deaths within people with CP can be related to respiratory issues. So we really need to be aware and take care of these people. Until recently, they thought that deformities were caused by spasticity and muscle imbalance. With further research, we still don't know the exact reason that deformities form, but we found contributing factors. And they're sustained asymmetrical postures, spasticity, muscle pathophysiology, muscle imbalance, and gravity. Through CPUP and other studies, they found that lying postures adopted in the first year of life are associated with the deformities that form later. And it's not just when they're sleeping. They found that when kids were being held and fed from one direction, or if they were positioned so that they were always looking one way, the deformities followed that direction. So it's important to get some intervention and change in quality of movement as young as possible. The body adapts to the stresses put on it. Wolff's Law, the bone remodels their architecture internally and externally, the shape, as the stresses are put on it. If we're not standing, we don't increase bone density, and the hip shaft angle, the head of the femur doesn't come down and change the hip shaft angle. Muscles do the same thing. If we have using our muscles and moving through full range of motion, they maintain the length so they keep the mechanical advantage. If we're not moving and we're not moving through full range, the muscle shortens and it adapts to the new ranges and therefore keeps the mechanical advantage. They've actually found recently that there are cellular changes in spastic muscle. It's not just that the muscle is tighter or whatever, there's actually differences in the cellular makeup of the muscle. And these include increased sarcomere length, and with increased sarcomere length, you get reduced numbers of sarcomeres. You've got reduced number of satellite cells and impaired function. The satellite cells are the stem cells that stimulate muscle growth, and stretching is a really good stimulant for them. But they find that even with prolonged stretching, the satellite cells don't produce more myofibers, and they don't know why. The muscles are reduced in size, and they tend to have longer tendons. There's one theory that I read that the tendons are longer because we keep stretching them, and the muscle's not getting any bigger, it's not responding, so the tendon takes over. And they've also found that the contractile tissue in the myofibers is being replaced with fibrofatty tissue and connective tissue. They've also found that it's after Botox, there's more fatty cells in the muscle than there were prior. So muscle imbalance, it results in asymmetrical postures. We go back to the body adapting. If we're not moving, we stay in these postures, the body's going to adapt, the muscles and bones are going to adapt and change. Gravity. In 1976, there were two Scottish doctors. One was a neurologist and one was an orthopedist. And they were concerned about the deformities that they were seeing in their clinics. So they did a study with 20 squint syndrome babies, which are babies that have deformities, postural deformities, but no neurological, no motor conditions, and 20 CP children. And what they found at the end of the study was that both groups developed postural deformities. So it wasn't the spasticity and the muscle imbalance. It was the effect of gravity on an immobile growing child that causes the deformities. In CP, we see common deformities. You've got lower extremity contractures, hip subluxation dislocation, windswept hips, pelvic obliquity, and scoliosis. And these deformities follow a pattern. It's a specific pattern. You get one, they all develop. The hip dislocates, the pelvis rotates, then the spine rotates. The body's adapting to the position and trying to maintain symmetry. Lower extremity range of motion is a leading, I think, when I work with CP kids, they all do. And from CPUP, they did a study on the development of lower extremity range of motion in children with CP. And they found that the range of motion starts decreasing in the lower extremities at age 2 and it continues through life. They found that the knee contractures come first for GMFCS levels 3 to 4. And another study found that there were 22% of the children with CP from age 1 to 15 had a 5-degree or greater knee flexion contracture. Another common deformity and one of the most common orthopedic deformities for CP is hip subluxation dislocation. It's measured by the migration percentage, which is the amount of the femoral head that is lateral to the acetabulum border. If it's 33 degrees or older or greater, it's considered to be subluxed. 40% or bigger, it's dislocated. Again, CPUP in their 20-year study, they found that 45% of children level 4 and 64% of the children level 5 developed hip dislocation. Scruton and Bard found that the migration percentage at 30 months significantly correlates with the state of the hip at 4 years. So if we can minimize the migration percentage prior to 30 months, we can affect hip dislocation. There's also a pattern. Most people who have the full triad of all the disabilities, of all the deformities, they start with the hip dislocation, then the pelvic obliquity, then the scoliosis. Hip dislocations can start as soon as a few months old. So it's important to follow these up and check. They've also found there's been studies that hip range of motion is not a good indicator for hip dislocation. I actually have a client that has a negative Galizzi, which I was always told was a sign for hip dislocation, but she's got a 40% migration percentage. So she's got a dislocated, dysplastic hip, but she's not showing a positive Galizzi. That makes sense, but people are different. Scoliosis, pelvic obliquity, and windswept hips, the trunk. How are we holding ourselves up against gravity? They found that children at level 4 and 5 have over a 50% risk of a moderate scoliosis by age 18. Over 30% develop pelvic obliquity in levels 4 and 5, and over 50% develop windswept deformities. I think if you look at the picture, we don't see, I think because our intervention has gotten better, we don't see children, young children, that have this many deformities or that significant, and they don't need as much postural control. There's still some out there, but I think we're doing better as a whole, but I think we can still do better than that. Another issue is bone mineral density. There was a study in Serbia that 90% of the subjects in the study had abnormal bone mineral density. And they found that children who were older than 9 and not walking, 97% of them had osteopenia. What this means is that their bones are weak, they're able to fracture, and they found that they did a study on fractures in children and typically developing children, and they found that the rate of fracture or the number of fractures wasn't that different, but the children with CP were fracturing with lower trauma. One of the major causes is transfers, and it's usually in the long bones. So what can we do? We can start a positioning program. Postural management program, the definition, and this is from the consensus statement from the Academy of CP and Developmental Medicine, It's a postural management program is a planned approach encompassing all activities and interventions which impact on an individual's posture and function. Programs are tailored specifically to each child and may include special seating, nighttime supports, standing supports, active exercise, orthotics, surgical interventions, and individual therapy. It also includes Botox, dorsal rhizotomies. Earlier, when everyone thought that deformities were only caused by spasticity, the focus was on preventing the spasticity to prevent the deformities. But then they found that the deformities were still happening, even though we were addressing the spasticity, which is why we now think the research is now showing that it's more than just the spasticity, and gravity has a huge effect on it. So postural management program, it started in the UK in the early 70s and 80s. And in the last 5 to 10 years, it's getting more attention here in the United States. When Fulford and Brown, who were the two Scottish doctors, found that the deformities were caused by gravity and not so much muscle imbalance and spasticity, the change of postural management, the management of postural deformities changed forever. It was fostered in the UK by therapists who are working with children and adults with neuromuscular disease. These therapists developed positioning programs and evaluation tools for postures and motor skills that they used in their facilities and found them to work and have shared them. Noreen Hare started in the 70s, and she was one of the first therapists in the UK to work with postural management. She described the body as a human sandwich, that the body is being sandwiched between the forces of gravity above us and our support surface below us. If we don't have the strength and the integrity and the control to fight gravity or to maintain our posture against gravity, we're going to fall into the surface. So the surface is important. The body wants support. It's going to go to the surface. The postural evaluation tools. Noreen Hare developed the posture ability scale, and she used it to assess children with severe disabilities. I looked everywhere. I could not find a copy of it. I think it was the original, and it's now not being used because Teresa Pontney, who works at Chaley Heritage Hospital, which is still in existence, worked off the PAS and developed the Chaley levels of ability to assess motor development and posture in very low functioning children. Pauline Pope built off the Chaley and the PAS, and she developed the posture and posture ability scale, and it assesses postures and abilities regardless of age or diagnosis. John and Liz Goldsmith developed the Goldsmith indices of body symmetry, and they focus on the thoracic cage, the pelvis, and the hips. The Chaley levels of ability. This is a picture of the score sheet for the supine part of it. There's multiple parts of it. I personally have used it when I was working with very low-level children and found it very helpful to get a more objective idea and a record of what they were doing. It was developed in the 80s at the Chaley Hospital, and they also developed positioning equipment, supine, sitting, standing. The Chaley Heritage Hospital is still in existence. They're still using the system, and you can find their website. It uses biomechanical and developmental changes to provide a basis for prescription and treatment of equipment. What they found at the Chaley Hospital was that if you combined postural management, postural positioning with the therapies, they were able to get better results and prevent the deformities. It has reliability and validity, and it has a positive correlation with the Alberta Motor Infant Scale and the Gross Motor Function Measure. Posture and Postural Ability Scale, or the PPAS as it's called. It was developed in 1990 by Pauline Pope at the Royal Hospital for Neurodisabilities. And this hospital still is in existence today. It was based off the PAS, and it evaluates their posture regardless of age or disability. Where the Chaley is an age, they use age as part of the evaluation. The PPAS can be used for anyone at any age. and the validity and reliability have been established. This is a score sheet. It's actually a score sheet that comes from www.applyebp.com, which is a really good website to go in, and they have trainings and courses. They developed this score sheet. It's a great eval. It's binary. It's either 0 or 1. You can use it to evaluate the effectiveness of equipment that you're using. So you can try, hopefully when you're trying postural equipment, you try more than one, and you can get an objective measure of the postures in both systems and find out which system can provide the best. It can also help to get parents to get buy-in. You know, going back to Lizzie, her parents didn't want to see her confined or restrained. But if you can demonstrate that the posture using a system is much better than their posture out of the system, it helps. And you can also use it to measure progress or regression, or see if your interventions are working. If you've been using something and nothing's changing, sometimes nothing changing is a good thing because it's not getting worse. But if you think there's an opportunity to get improvement, then you want to change your intervention. And the PPAS is a good way to track how you're doing that. The Goldsmith Indices of Body Asymmetries. It's a non-invasive qualitative measure of body symmetry. It has validity and reliability has been demonstrated. And the score is reflective of the symmetry of the gross geometry of the body. They concentrate on the thoracic cage, the hips, and the pelvis. The con with it is it requires special tools and training to do. The Goldsmiths were also the first ones to develop an objective measurement of windswept deformity. And their website, www.simplestuffworks.com, is actually being run by their children now, and it's a great source of information. So what is 24-hour positioning? We said that a postural management program encompasses therapy, surgery, medical interventions such as Botox, dorsal rhizotomies, baclofen, and active movement. So in positioning. So the 24-hour positioning part of it occurs in 3 different orientations. It occurs in standing, lying, and sitting. So pretty much where you are at any point in the day, you're in one of these positions. It uses external supports to assume and maintain a symmetrical body posture as comfortably as possible in all 3 orientations. It has to be comfortable for the child. The child can't tolerate it. If the child can't tolerate it, it's not going to do any good. There's also the thought is that if the positioning limits the child's ability to access activities, then the positioning should decrease so that they can access the activities. You don't want to limit function by using postural management. The caregivers need to make a commitment. It's part of the daily routine. If you can get it into their daily routine, then it's great. I mean, how many times do we send home instructions and they never quite get around to it? It's not convenient. So you really need to work with the caregivers to make sure that you get the program that meets everybody's needs, not just the child's, or more importantly, not just yours. I mean, we all have goals, we all have ideas of what things should be, but we're not the one doing it. So I think we really need to get the family and the caregivers involved in it. You've got to train them. They've got to have adequate training. There was a study done a couple of years ago, a survey of caregivers, so it's a low level. But what they found that most caregivers who abandoned using the systems were ones that felt they didn't have adequate training. They weren't really sure how to use the system. It was brought in, set up, but if something moved, they didn't know how to fix it. And they also didn't get follow-up. Whenever you start a system like this, a program like this, you need to have regularly scheduled follow-up, not just with the child, but also with the family to find out how things are going. Are they working? And also you can measure if there's changes and you need to change the system. And on the other side, if it's not working, you need to find something else. You can either buy the supports commercially or you can home make them. The website Posture 24/7, I have it later, has great instructions on making homemade ones. So we're going to look at standing. When you're choosing a standard, we all know there's multiple standards out there, a lot of manufacturers, but each one has a little bit different. So you really want to first figure out and do an assessment of the child. And what do you need in a standard? Do you need head control? Do you need trunk control? Do they have contractures? How bad are the contractures? What do they need to maintain body symmetry? It's not just holding in an upright position. You need to hold them up in an upright position aligned. As we all know, the body works in gravity and alignment. It's designed to be aligned, and that's where it functions the best. If you can't get a good alignment in gravity, you're going to collapse. We're going to sag. If you're out of alignment, you don't have the mechanical backsides, so you fall. Are you looking to work on bone mineral density? Is the child at risk for hip dysplasia or dislocation? Transfers. You're not going to be doing the transfers. I mean, for as long as I've been practicing, I've been putting kids in and out of standards. It's pretty easy to me, but for somebody that, a parent, it's not that easy. So you need to find out who's going to do the transfer. What are they capable of? What do you need to do to make that transfer successful, and what product can get it for you? And also you need to have growth potential. And most payers will only buy a new piece of equipment every 5 years. If the kid's going into a growth spurt, or you figure they're at the age, make sure you leave some room for growth. There are 4 types of standards. There's the combination sit to stand. There's a standing frame, table, one position. So you get your upright, your supine, your prone. It doesn't change, it's there. And then you've got the multi-position. There are now standards that you can do prone, vertical, supine, sit to stand, all in one standard, all without having to move the child. And then the last is the dynamic mobile standard. These are important because independent mobility has a positive effect on cognitive function, socialization, and giving the child a sense of pride and ability to achieve and not be dependent on other people. I remember years ago, I worked with a young girl whose parents waited on her. She never needed for anything. She didn't move. She didn't have to. Everything came to her. Kids will learn and move more and develop motor skills if they need to move, and they can move. And a dynamic standard can give them that ability. This is a supine standard. It's very supportive. So if you've got somebody with limited trunk control, limited head control, these standards can provide the support you need. They don't necessarily accommodate moderate to severe contractures. It's a linear system, and it's used by the straps. You have a decreased flexor effect because you're out of the line of gravity. You're back, and gravity is helping you go back into the standard. It's pushing you back. And unfortunately, you do have a con is the extensor tone and tonic labyrinthian, but that pretty much comes with everything. This is a prone standard. You have the decreased extensor effect because you're forward, but then you have an increased flexor effect if you don't have enough support. It's a functional position. You're forward, you're active. They've been calling it an active position because you're ready. Think of it. Look at me. I'm leaning forward. I'm active. I'm engaged. You can get weight bearing on your shoulders, some co-contractions. I think one thing I forget to say is visual fields. I worked with visually impaired children for years. And if they've got a field cut, especially if they have an upper field cut, you're putting them in a prone stander, but they can only see from here down. So they're going to always be extending their neck to see around. And there goes the body symmetry. You become in a sustained posture because they've got to have their head up so they can see, and you could get deformities. The cons is the flexor tone, the tonic labyrinthian reflex, transfers. It's not always easy getting someone into a prone stander. And I was talking to one of my colleagues a week or so ago, And she mentioned the head to butt. I don't know how many of you do it, but I've done it for years. When you get them in to get them stable, you put your head into their butt to hold them in position till you can get the straps on. So you got to make sure the parents know how to do that, or you find a different way. It's a linear system again, so it's got minimal contracturability to accommodate, and you've got to have head control. To me, there's nothing worse than seeing a child in a prone stander with a Hensinger or a neck support, or in the old days of the Mulholland, the chin support up to here, but then they can't move their jaw. So try to get a standard that's going to meet them where they are, challenge them, but not inhibit them. A vertical standard is just what it says. Totally upright, linear system. You have greater weight bearing because you've got gravity going through the whole body and a direct line down to the feet. If the child is semi-independent, semi-mobile, or can at least pull to stand, they can do an independent transfer. There are some standards that are strap standards where they can pull their wheelchair up, put the strap under their butt, and use the crank to bring them up to standing at a standing platform. I'm showing my age again. When I first started in therapy, we were using standing boxes. You can still see them every once in a while, which is basically a wood box. We added padding. You put the child in it and you quickly close the door so that you could maintain their alignment. We didn't have good alignment because they were able to move within that system. A vertical standard, you can get good alignment, you can control where the postures are, and you can provide the supports where you need it. Again, linear, can't do a lot of contractures. You've got to have better trunk and head control. And if it's a dependent transfer, it's along with the prone stander. It's hard to hold them in. A mobile stander enables independent mobility within their environment. They can get from point A to point B. They can be prone, supine, vertical, or sit to stand. There's multiple different ones out on the market. Sometimes getting them paid for is not that great, but they are available. This is a sit to stand standard. There are a few different models of sit to stand standards on the market. Some of are just a plain sit to stand. You transfer into the sitting position. You can use a Hoyer lift if you've got a larger child. You can do a slide board. You can do a two-person lift if you have to. This one actually goes to supine so that you can do a level supine transfer. You can pick the child up, place them in at supine. They're fairly stable so that you can get the straps attached. It accommodates contractures because you can, especially hip and knee flexion contractures, you only stand as straight as the body allows it. What I really like about this one is if you've got someone with moderate hip and knee flexion contractures, if you're standing and you're standing vertical, gravity is just flexing you down. Where this one, you can put it into supine a little bit, let gravity help hold the body back into position, but you're still getting weight bearing. You're not getting 100% of the available weight bearing, but you're getting weight bearing. And as the range of motion increases, you can stand them up higher and higher. It's got more moving parts, and it really needs to be specifically adjusted to the child and kept on. So again, educating the caregivers so that if something comes out of alignment, if they don't know how to fix it, they know who to call to fix it. This is a multi-positional standard. So in the same standard, you have supine, vertical, and prone. Some of them have up to 30 degrees of independent leg abduction. You can do a supine transfer. What's nice about this one is that you can change the position without changing the child. You put them in and you can stand vertical for a while. If they get tired, lean them back, get them out of gravity, let them rest a little bit. If it's time to work on something, bring them forward, get them into that active position. It's quite versatile. It has a lot of growth. The con is there's more moving parts. A lot of families are intimidated by something with so many moving parts. So how can standing assist with preventing deformities? There's a lot of research done on hip development that's standing in 30 to 60 degrees of total abduction. So that means 15 to 30 degrees of each hip. You may not be able to get to the full 60 degrees because that's quite a lot, especially for a young child, but you get as much as you can. When you're moving them into abduction, make sure that the pelvis doesn't move. If you've got limited range on one hip and you're trying to get the abduction, because you got to get that abduction, and you see the pelvis start tilting, you got too much abduction. Bring it back, maintain a level pelvis. You want symmetry. You want alignment through the whole body. They have found that if you stand 60 minutes a day in 30 to 60 degrees of abduction, it has a positive effect on the hip development. In Sweden, they did a study that they were standing 10 hours a week, but it was able to reduce the migration percentage and kept it and preserved that range for 7 years. So you don't stop standing. Even if a child has hip surgery, you still need to stand after. At Chaley, they found an 18% of reduction of hip problems after 5 years with a postural management program, including standing. So why do you want the abduction? It's physics. No matter how much some of us hate it, it's physics, and that's how the world works. When you stand in abduction, you take the head of the femur and you move it into the center, more medial in the acetabulum, more towards the growth plate and not on the edge of the acetabular rim. Again, and then Wolff's Law takes over. The body accommodates to the stresses. The stresses are being put on the center of the acetabulum. It grows to accommodate. They found that bone density, actually some of the earliest work on bone density was done here in Boston, but was never published by Dr. Katz. But they found that if you stand 60 to 90 minutes per day, 5 days a week, it has a positive effect on bone density. So why do you want greater bone density? You want to reduce fractures. They found that children using standing devices have 4 times fewer fractures than those that don't with low trauma. They found that standing does affect lower extremity range of motion. In a 6-week standing program, they showed an 18-degree mean increase in knee range of motion across the participants after 6 weeks. That's pretty good. They then did a non-treatment session. They stopped standing for 6 weeks, and there was a mean loss of 14 degrees. What I'm trying to get through is that you can't just stop standing. You've got to be consistent with it. You've got to continue it. And you should probably continue it until they've reached skeletal maturity, which in some cases is younger, in some cases are prolonged. I know in the Charge syndrome population, skeletal maturity is usually delayed 3 to 5 years to the typically developing child. If you want to work on hip abduction, on hip range of motion, you add the abduction. And there are multiple standards that can do it, more for young children, not so much for adults. Standing does have a positive effect on lower extremity spasticity. There's not a lot of evidence on this. There are 2 low-level studies that show that if you stood for 30 minutes, the tone in the lower extremities reduced, and that was maintained for 30 minutes. The dosing is 30 to 45 minutes per day, 5 days a week, can have a positive effect on spasticity. Anecdotally, I've had a lot of clients, and both adults and children, that report their tone is better after they stand. And they continue. Unfortunately, there's no hard evidence. Lying. The considerations for lying are that humans spend approximately 1/3 of their day lying, and it's increased for CP. I actually read a study last week that it says children with cerebral palsy spend 42% of their time either sleeping or in the lying position. That's a long time in one position, so we need to take advantage of this position. In supine, you've got the maximum base of support. When the body's supported, the tone's going to relax. The body's not going to be looking for support, so you can work on the systems. It's also longer than any therapy session you have. And without gravitational support, the forces can alter the rib cage shape. They actually show where the rib cage rotates. If you look at the Goldsmith indices, they show you, and they use the sternal-spinal line to watch the rotation. If you've worked with older CP kids, there's a lot of rotation, a lot of chest deformities, and the shape of the chest is changed. So you need to support in supine. They also found, remember we said that knee flexion contractions come first for children with CP? When you're lying supine and your knees are flexed, the body's looking for support, so they roll, and then you start into the windswept deformities. This is supine, and what you want to do is you want to have the body positioned, the head in neutral, everything in neutral. You want to be aligned. You want to have a support underneath the legs, because if you don't, the pelvis will go into an anterior tilt. So with a little bit of support, you can maintain the neutral pelvis. There was a study out of Norway that I read working with infants, 4 months old, both normal, typically developing infants and children with mild neurological. And they found that by positioning and putting them in a little bit of protraction, a little bit of pelvis support, that they had a significant increase in general movement and in specific movement just by using the positioning. Prone, you want to support under the chest, aside. Again, you want the supports for symmetry. One of the main things that's important when prone lying is to make sure that the child's head is not turned in the same direction all the time. Remember what we said, early lying postures? Well, if the head's turned to the right, the body's going to go to the right. It's also important for development. I know everybody does that. We went to back to sleep years ago for SIDS. And what they also found after that, I read some studies that said there was an increase in speech referrals in elementary schools because oral motor skills were decreased. Part of being in prone is you get the stimulation on your mouth, you get your hands to your mouth, your hands are in front of you, and it's easier to develop extension and motor control because you have a surface on your back, you're pushing up against air. Side lying, it's not really total side lying. You want to be a little bit out. Some of the benefits of side lying is you can eliminate the asymmetrical tonic neck reflex. So you're not getting an increase in tone on one side, or if you've got an older child where it's starting to become obligatory, you can have more midline function. Your hands are in front of you. You can purchase commercially available sleep systems. On the left is the Symmetric Hip Primo. It's a Velcro sheet with plastic. They look like bookends that are padded, that are put on. The sheet has a grid, and then you put a mantle over, or it's like a sheet, but it's a thermoregulating mantle, which helps with the heat. One of the cons, or one of the arguments with sleep systems, is kids overheat. So you want to pay attention to that, and this mantle helps. You can also, there are also pillows that go on top of the sheet, and you just put it on the child's bed, use the mantle. I've put a regular fitted sheet on top of that, and they're good to go. Again, you need to train the parents, because if they move out of position, you need to know where to put them. I've worked with symmetric kits mostly, and they actually provide you little sheets where you can draw and put stickers on and leave it so the parents know where they're supposed to be. You have to take them apart to wash them too. The Lecky Sleep Form, for those of you who remember the old Salmons Preston Versa form, it works like that. It's beads, and then you take the air out to make it solid. The Junkstrema is actually a mattress replacement. It's a whole bed system. The mattresses, you can see, are strips of foam, and underneath is the supporting surface for the supports. So they go between the slits and they lock in down below. These can all be quite expensive. I want to say they're over $1,000 and maybe closer to $4,000. But you can make homemade sleep systems. This is from posture247.org and Eleanor's project, which is, they go down to Peru, I think it is. But you can make them out of, this one's made out of pool noodles, shelf lining paper, you know, the non-slip stuff, so you don't want them moving out of the way, and towels. You can use teddy bears. You can use blankets, towels, whatever you can to make the support, and it doesn't have to cost a lot. There are also commercially available lying systems because we don't just sleep. We need to be out in the environment and interacting with the environment, but we still need to be in the supine or side lying position. So Tumble Forms has a great set. They've been around forever. And they have ones that you can put the pieces, so you can do side lying, you can do prone, you can do long sitting, all with one system with a little bit of Velcro. Squiggles has the Lucky Squiggle system, is along the same ideas, but it's softer, where the Tumble Forms is a little rigid foam, but they're all available. Or you can make your own. Sitting. I am purposely not doing a lot on sitting today. I think there's a plethora of information out there, and we're just going to go quickly over it. So you want the pelvis in neutral. You want to establish a base of support, because you've got sitting is the support, that's the base that's going to support the trunk. We all know physics. You got to have a base of support with the length of the lever arm so that you can maintain your balance within it. The legs in slight abduction, they find that about 10 to 15 degrees of abduction works for children, and it's comfortable. You don't want them way out like they're in a spica cast. Then the hip goes into posterior tilt. You want neutral supports in the trunk, so lateral supports, hip guides. If they're still having trouble maintaining or assuming a neutral posture in the trunk, use tilt. Get them out of gravity, get them out of the direct line that's going to collapse, bring them back and let gravity help. And you want the head in good alignment in a neutral neck posture. You don't want the head forward. You don't want the head back. You want it neutral. These are some commercially available systems for young children. They've got the abduction, and they've got some of the trunk support. The issue I've seen with them is a lot of the children adopt a posterior tilt to stabilize. Again, they're going to shorten the lever arm of the trunk, come down and be more stable. And sometimes it's hard to get them out of that posterior tilt once you get them out of these little systems. The Lucky Squiggle system can be used as a long sitter. We used to use that to stretch hamstrings. Didn't really work most of the time, floor sitters, because they usually went into a posterior tilt. And then there's custom seating systems. We all know there's multiple brands out there, different versions, different sizes. I just happen to have a picture of the Sunrise Kid Cart. So postural management is gaining momentum in the USA, and part of that's because of a program called WWW Posture 24/7. It may be a hyphen instead of a dash. And in 2016, they started the Montana Project, which was started throughout the state of Montana. They had 30 participants. Most of them were older, adolescents to young adults. They didn't make any changes to their daytime positioning, but they did add nighttime positioning. None of these people had nighttime positioning before. At 6 months, they found 80% of them improved body symmetry. They were less contracted, less deformed. Almost 80% of them had improved quality of sleep. If the child can tolerate, part of the tolerating of the positioning, if it's too much and it interferes with their sleep, then back off. And over 50% had a decrease in pain if pain was an issue. I think that's pretty good for first time. They continue working, and I really do suggest you go to their website. They have a lot of instructional sheets on how to make homemade systems, how to use them. And it's a really good place to start if you want to do sleep systems and get information for the parents. Hip surveillance in the USA. As we talked about, Sweden has CPUP, which is part of hip surveillance, as well as other scoliosis, other postural deformities and deformities. Actually, in 2011, they started looking at upper extremities and keeping data on those too. The Scandinavian countries are all joining together to have one database, which will be amazing, we can see. The United States doesn't have it. They did a study, Posner did a survey in 2020 and found that each practice, each hospital had their own set of rules, set of standards in the way they practice. And there was no consistency across any of the hospitals. In 2017, the American Academy for Cerebral Palsy and Developmental Medicine published a care pathway for hip surveillance. And Posner developed their radiographic screening in 2021. Oops. This is the American Academy for Cerebral Palsy and Developmental Medicine's care pathways. If you look at levels 4 and 5, you'll see it follows along a lot like CPUP, that it's every 6 months, there's a physical evaluation and a hip x-ray. This is Posner's guidelines. Posner is the pediatric orthopedic surgeons of North America. Sorry. Again, levels 4 and 5, every 6 to 12 months, x-rays and physical evaluations. So what's the evidence? As I've said along, there's evidence on bone density, low-level evidence for range of motion, spasticity. The evidence on postural management is usually low quality and low level. It's like level 5, level 4s, level 3s if you're lucky. But what I think we can find through the greatest evidence is what they've been able to do in Sweden. They've decreased surgical intervention for deformities, they've decreased hip dysplasia, and they've maintained it for over 20 years. I think that's pretty good evidence that it does work. I also want you to remember that it's not just the positioning. Postural management is active therapy, movement. It's important for these kids to move because remember we said it's sustained postures are what causes deformities. The positioning, surgical intervention, medical intervention. CPUP, part of their success is that they recognize early when surgeries have to be done, and the surgeries are done. It's not replacing surgeries, it's everything together working towards a total goal. So I hope you've enjoyed this, and I hope it's at least piqued your interest to go investigate further. We can start positioning early. If you notice an infant is starting to get a preferred posture, get positioning in. I would say 3 to 4 months. Sitting, make sure they're aligned, make sure they have a good place, make sure the parents know that when they carry them, not to keep them all squished up in a ball. And standing, you want to start standing when a typically developing child would pull to stand, which is usually around 6 to 9 months, unless you're my granddaughter and you do it at 3 months. I did not help her. You want to incorporate movement and activities frequently out the day. Again, sustain postures. These kids aren't able to move on their own, so we need to help them. We need to change them. We need to challenge them with movement activities. And you want to participate in a hip surveillance program. If you have a child you think's at risk, get them hooked up with an orthopedic center, get them hooked up with a physiatrist, somebody who's going to be able to x-ray and monitor that hip and implement interventions if necessary. Any questions? And I think I ran over, I'm sorry.
Yeah, really quick before, thank you, Marianne. Really quick before everybody logs off, just a reminder to do the survey that will pop up in most people's browsers at the end of the webinar, or there will be a link included in the email tomorrow. You must complete the survey in order for us to generate your CEU certificate. While I compile the questions here for Marianne, there are just a couple. I'm going to start a poll that everybody can fill out if they'd like to. I forgot to run this at the beginning, but it should be showing up on your screen now. And the first question, Marianne, if they have asymmetrical hip range of motion, do you recommend abducting to symmetrical range or to go max range of each of the hips?
I would do symmetrical because you want the pelvis and the rest of the body. If you abduct one more than the other, it's going to affect the whole chain up.
All right. Next question is, are sleep systems often covered by insurance with an MD order?
I have actually gotten them covered by Mass Health here in Massachusetts for adults. It's not easy in writing a letter of medical necessity. Actually, we're going to have a podcast in May or June on funding. You really have to spell out without any question why they need the system, what's happening, what you're seeing, and what the system can do. And if hopefully you can get a trial of the system, it's not always easy. But it can be done with perseverance. It's not going to be easy. And email me if you want some help. I used to be a reviewer for Mass Health, so I have a kind of an insider's guide on what they're looking for. And Nancy Perelich, who's also our funding specialist, can help. Sleep systems, email me.
All right, and then I haven't seen any other questions come through, so I think that covers us for today. Appreciate everybody's time this afternoon.
Thank you guys so much. It was nice to share some time with you. My contact information is on the bottom. Feel free to email me, call me. Email will probably be better, but I am available. And thank you again. Have a good night.
All right, take care, everybody. Look for your emails in the future. Again, we're going to be doing a series of webinars, so there'll be a minimum of 3 more yet this year. Watch your emails for more information. Take care. Have a great night.